Yeah, thank you very much. Thank you.
Okay.
Yeah.
So thank you, my dear friends. And I'm very happy to give this presentation on large intraventricular tumors. This is one of the more complex neurosurgical problems and one of the most difficult neurosurgical problems. And one has to be absolute neurosurgeon, skilled in microneurosurgery, skilled in all kind of tumor surgery, skilled in hemostasis, skilled in all the aspects of neurosurgery. So this is the topic and I want to discuss. So recently, about 4 or 5 years ago, I published this series of large lateral ventricular tumors. So this was my experience of 145 cases of lateral large. So this was one of the largest series published in the literature. Several years ago, I published my series of large intraventricular tumors this was a series of 50 cases, which I published in 2006. This was also one of the largest series. Colloid cyst, I published several years ago, my series of 105 cases. That was also 20 years ago, 22 years ago. Now my series is very huge. And this article is one of the most highly cited articles on this subject. So on the basis of my big experience of intraventricular tumors, I wish to make this presentation. And ventricular anatomy, we have just learned and heard. Corpus callosum is like, you see, this kind of veil. The whole of the ventricle, whether it is lateral ventricle, whether it is temporal horn, is covered by this kind of a cloth. And this ventricle, when we have to enter the ventricle, we have to enter through either through the corpus callosum or through the fibers of the corpus callosum, like tapetum, like it goes over the temporal horn, it goes over the lateral ventricle. So this is the ventricular anatomy covered by this kind of a veil. And this beautiful article we wrote on corpus callosum. And I never, before we wrote this article, I never thought that corpus callosum is such a huge and massive structure. It is not just a midline structure. The fibers goes along the roof of the lateral ventricle, along the roof of the temporal horn. It goes in the frontal horn. So corpus callosum forms indeed a very big foundation for the brain. And it makes the infrastructure, the highway for the brain. And this corpus callosal anatomy we have to learn very beautifully. And the fibers are transversely traversing. That is one beautiful aspect. We have heard about approaches to ventricle from here. But what I'm going to talk today is about the lateral ventricle. When we talk of ventricular tumors or intraventricular tumors, other than colloid cysts, which are at the junction of the one ventricle and the one horn, lateral and the third ventricle, intraventricular tumors in general are of large size because they have space to grow in the CSF. They just go on growing, and they grow in a huge size when they are diagnosed. Other important thing is majority of these large lateral ventricular tumors are benign or of low-grade malignancy. So this is another very important fact that they are large. They are in the ventricle, but they are low-grade. Majority of intraventricular tumors are highly vascular and difficult. Sometimes it can become very difficult to have hemostasis. So vascularity is another very important feature. Another important feature is the patient comes with very marginal symptoms. They may have just headache, they may have just some kind of giddiness, some kind of ataxia, and the tumor is huge. And the other thing is most of these fellows are young age. So this makes the intraventricular tumor surgery quite a complex and challenging issue. Most of the tumors in the lateral ventricle are large, as I said. They keep on growing over the years, until they come with some marginal symptoms of headache. And central neurocytoma is one of the issues in this tumor, one of the more common tumors. And these tumors are huge. That is one. Second thing is the patient has very marginal symptoms. They come laughing to you and they come walking and they have very marginal symptoms. Third thing is many of these tumors are heavily vascular. You see this tumor, quite a large tumor, and blood vessels within the tumor you can see. from here, from here to atrium and complete. These central neurocytomas are in the lateral ventricle. They are supposed to arise from the septum pellucidum. Sometimes they grow in other parts of the ventricle, but majority of them are in the lateral ventricle. In the atrium and in the occipital horn, less common, but this was also central neurocytoma in a less common location. SEGA, or subependymal giant cell tumor, associated usually with tuberous sclerosis. They may have signs and symptoms of tuberculosis, but sometimes this intraventricular tumor may be a first manifestation of tuberous sclerosis. And tuberous sclerosis can be, these tumors are relatively soft. These tumors are relatively, but here also the tumors can grow into a huge size, a very large size, and there can be calcification in the tumor, and there can be, you see, this kind of edema is usually in more aggressive form of tumor. Normally, you don't see edema in intraventricular tumors, but this is one tumor. Meningiomas are other tumors which are very common intraventricular tumors, and most of these meningiomas are formish in nature. They are large and huge in size, and they are quite significantly vascular. Most of the vascularity comes from the medial aspect of this tumor. So these are large, huge intraventricular meningiomas which can grow into, majority of these meningiomas are in the region of atrium. They can be in any other area of the ventricle as well. Glioblastomas are relatively less common, but this is the case of glioblastoma in the region of lateral ventricle. Choroid plexus papilloma is another relatively not very common, but common tumor, relatively easier to remove, relatively soft, sometimes can be vascular, but they are benign and completely benign tumors. Sometimes these tumors can be huge and like this, and they can be atypical choroid plexus papilloma. Sometimes there can be choroid plexus carcinoma like this one. These are rare, of course, very rare tumors, but they can be there. Hemangiopericytoma, this is a huge intraventricular tumor that you see here. And you see on T2 quite dark. And this was a heavily vascular tumor which was removed. And this was hemangiopericytoma, of course, very rare tumor. Intraventricular tuberculomas are also can be there, but they are obviously very rare tumors. Intraventricular cyst, intraventricular epidermoids, as we have seen earlier, can sometimes, but extremely rarely, if I have done whatever numbers I have done, but extremely rare to find intraventricular epidermoids. Choroid cyst can be in the ventricle, of course, in the region of foramen Monroe, and this choroid cyst was in the region of velum interpositum, a rare kind of location. This was the very beautiful looking dermoid cyst in the lateral ventricle, in the like a colloid cyst. And this is sometimes colloid cysts can become huge and large, but majority of them are small. And we know colloid cyst very well. Pineal tumor, of course, I'm not going to discuss. So this is the main title of my presentation today, large lateral ventricular tumors. Majority of the lateral ventricular tumors can become huge. You see, they become huge. And here, and as I mentioned to you, these tumors have some good points and some bad points. If you see in this tumor, this is soft and necrotic, cystic, and all those things are there. The other good thing is you see, the tumor can be necrotic, cystic, the lateral ventricle horn is large, and all those things that is there. The bad thing is the patient is young and the patient is marginal symptoms. And the tumor is heavily vascular. You see, the vascularity is so much, and to operate on these tumors, you need a big exposure. I'm not saying massive exposure, but a big exposure. And you have to be under control of the bleeding throughout the operation. I can say that these tumors form one of the very important chapters in our subject of neurosurgery, and you can have actually a death-forming operation. You can have hemiplegia or hemiparesis and aphasia. You can have huge complications following this surgery in a relatively asymptomatic or marginally symptomatic patient. So these are the issues. Now here, the approach to this tumor is, one is transcortical from here, from the cortex. I like to approach from the region from the side of larger extension always. Majority of these tumors are central neurocytomas, and they arise in the midline in the septum, and then they go here and there in the ventricle. I like to do transcallosal operation, transcallosal. In my series of 145 cases, majority of them were central neurocytomas, some were SEGA, some were choroid plexus papilloma and ependymoma. And then these secondary tumors which invade into the ventricle, gliomas and these kind of gliomas, PNET and ATR. If you see this slide, in this majority, most of these cases are in young age, from 11 to 40, majority of the tumors are in young age. And if you see the symptoms, headache and vomiting are the major symptoms. Some patients come with convulsions, but not many come with altered behavior, not a single patient altered behavior, very few, some urinary incontinence. No patient has come with drowsiness. No patient has, very few number has come with limb weakness. So most of the symptoms are just headache and if you see this slide, there are many tumors which are huge or massive in size. Now, when we are going to operate on these tumors, we have to be very sure that we keep the patient and the relatives in confidence. We have to tell them that if we are able to remove this tumor completely, your child, your son or daughter will have a new life completely. They are benign. You remove them, they are cured. On the other hand, you can have a death, you can have a bad deficit, and you have to be, real in this. You can never be artificial in neurosurgery in general, and particularly in this case, you can have a massive complication because of the large size. So what we have to do is when we have to operate, we have to have safe brain retraction. We have to learn how to retract the brain of the fox. We have to learn that. And we have to be master of retraction in a tight looking brain. We have to work in a very narrow corridor. We cannot have, small corridor, but narrow corridor. How to make it big and how to make it wide is our learning process. Then we have to learn the art of tumor demolishing, how we demolish the tumor. If you go on coagulating, you will never be able to remove these tumors. You will actually kill the person before the operation is finished. You have to learn to demolish the tumor in a vascular territory without coagulation and minimum real coagulation. And we have to learn the art of controlling the bleeding in the depth. It's difficult. These tumors can become difficult. And more than anything else, we have to avoid damaging or coagulating the part of the tumor by the side of foramen of Monro, where important projection fibers are traversing. We cannot damage surrounding area. So these are the critical issues in these large tumors. And as we have heard, my approach is centered on the coronal suture. I like to operate in front of the coronal suture, big incision, 2/3, standard 2/3 in front, 1/3 behind, but I will approach the midline. There is an option of tapping the ventricle if it becomes too tight or to this. Like if you see this brain, you can retract and expose the corpus callosum. The other thing which I have learned to use is if sometimes the brain is very tight, you can come through the cingulum and then instead of going right up to the corpus callosum, you can take enlarged tumor incision over the cingulum and go through the corpus tapetum of the corpus callosum and enter into the tumor. I find this kind of transcortical much better than going from a big, huge transcortical. Other thing is we have to take an incision in the region of coronal suture here in the corpus callosum. We cannot go behind. If we go behind, you can have very big disconnection syndrome by themselves after surgery. And some of these patients who develop a deficit may develop a deficit due to disconnection syndrome. Other thing that you have to learn is to understand is transverse. These fibers are transverse. So in colloid cyst, I like to take a transverse incision. In this kind of large, huge intraventricular tumor like this tumor, this is a huge tumor. This is if you see, there is a huge arteries and veins and all those things. But the good thing is you see the necrotic area. So this tumor, I like to come from interhemispheric and then go through the cingulum, through the tapetum and enter into the ventricle. So that is my surgical strategy. And then I will show you quickly this intraoperative pictures, you see the tight brain, hugely tight brain. Now I have retracted, but if you're not able to retract, you can put a tap, you can tap the ventricle. I don't need tapping. Very rarely I do, of course, tapping, but very rarely it is required. Then I am cutting through the cingulum, and then I'm going, you see, more important is you have to avoid coagulation as much as possible and limit your coagulation. And learn the art of breaking the tumor. Learn the art of demolishing the tumor without coagulation. In intravent and have a huge exposure. You cannot do limited exposure and start doing this kind of surgery because, as I mentioned, there is a big potential of death in this patient and big potential of hemiplegia and hemiparesis. And now if you see carefully, when I'm sucking this tumor off, the large vessels are coming into my suction. And these vessels need to be coagulated when they have to be coagulated. And then I'm gradually, this is an unedited tape. As now I'm breaking the tumor, I'm sucking away the tumor rather than coagulating. You see, up till now, very little coagulation has come into picture. And then I will hold this suction and see how the vessels are coming in my suction. And this is a very important technique in general, but in intraventricular tumor, this is the technique of hemostasis. You cannot go on coagulating and coagulating inside the tumor because it will be an unending experience for you to, and the operation will never end. You have to break the tumor, and ultimately because of the soft nature. So you have to use the soft nature of, you see how the vessels are coming in my hand, and then I am coagulating. This is, I think, a very essential, and you have to have control. You have to have the retractor. You have to retract the brain. In my opinion, these kind of large tumors, you just cannot compromise on your exposure. You just cannot compromise on, you cannot go on operating these tumors for 10 hours or 15 hours. You have to do a quick fire resection of these tumors. You learn the art of breaking the tumor, and then avoid any kind of work around the foramen. You see now the brain has relaxed, and now I will comfortably retract the brain anteriorly and posteriorly, and then remove the tumor in the atrium and things like that. So over the years, we have got a very beautiful experience in removing this tumor. One and most important thing that you should remember is, if you are able to remove this tumor radically, you cure the person. The person is cured. He will not need any radiation treatment. He will not need any kind of adjuvant treatment, and the story is ending, and you have a happy family, happy patient. On the other hand, when you take corpus callosal incision, or you have any kind of damage, I am not saying, I have already said that you can have a huge complication in these kind of massive tumors, to the extent that these are one tumors where you should be clearly in sync with the relatives, clearly in sync with the patient, that you can have a big complication following surgery. And I have learned to, in difficult ways, with here and there situation, but this is a very important neurosurgical issue. On the other hand, if you don't operate, there is no other treatment also. You have to operate, and you have to resect, and you have to resect safely, you have to resect radically, and you have to resect in a way. And your most important is, you have to achieve hemostasis in kind of this. You see the bloody feet. You cannot just, on the other hand, you just cannot go on. You see how the vessels are coming in my section, and this is a good way, in my opinion, to get hemostasis and to coagulate. So in general, this is the, let me go to the next slide. And in the depth of the lateral ventricle, there are internal cerebral vein. Majority of feeders are coming from the midline, from the choroid plexus, and you have to coagulate. Most of the feeders are of unusual kind. Many of them are neither arteries nor veins. They are unusual kind of veins. So you see this huge tumor. Can you imagine this huge tumor with marginal symptoms? Young patient, family, patient coming, laughing to you and excited for surgery. And this tumor, you can create a very huge complication, you must remember. But if you remove it, you give new life. So in our subject of neurosurgery, we have the potential to give new life. We have the potential to kill the person. We have to learn the art of tumor resection and dissection. And these kind of tumors can indeed be removed very beautifully. And we have got over the years, several patients. Meningiomas in the lateral ventricle can be big, as I mentioned, and majority of them are big. Majority of them are formish in nature. Majority of them are very highly vascular in nature. How to get into meningioma? Sega are relatively soft tumors and relatively easier to remove, relatively avascular to remove. I like to remove all these tumors by intrahemispheric transcallosal route. So this is one Sega I want to quickly show you. You see the brain is not very tight here, and I'm retracting the brain. Your incision has to be right, up till the far, so that you retract the brain, get to the corpus callosum. In this situation, this white structure is corpus callosum, and then you enter into the ventricle. You have to have big anteroposterior exposure. You cannot do a limited operation here. You just cannot do a limited operation. You have, and also the arteries and all those things have to be quite lax and comfortable. You see, this is the corpus callosum. Then you take the incision and then you work in the tumor. Then you break into the tumor. You see, these are Sega, these are soft. These are relatively good tumors to operate. Quick fire, you can remove this tumor in 20 minutes or half an hour. If you just go on working on this tumor for 10 hours or 15 hours, then of course, then it will be the brain retraction can become difficult, exposure can become difficult, you can damage the surrounding brain. More important is limit your coagulation. In this kind of Sega, there is no need for any coagulation. Very little coagulation. You just don't work with bipolar in your hand and keep on coagulating. Basically, break the tumor, and that is how you have to break into the tumor and get the tumor out. Radical tumor resection in Sega, these are relatively benign tumors. You don't have to give any kind of adjuvant treatment. And they are soft tumor. I'm removing essentially by suction. This is controlled suction in my hand, and these tumors are removed. Essentially, I can have in cases of vascular tumor, you can have the possibility of wider retraction, wider exposure. So I like interhemispheric transcallosal approach, which is a good option for these kind of tumors. And this is another central neurocytoma, which has been removed. You can see here. This is another one, beautiful. So in my years of neurosurgery, these kind of tumors, you can have the potential of giving new, beautiful life. This is Sega. Now you see this slide of mine. This was the article I published with 145 patients. Now you see hemiparesis, hemiplegia, aphasia, and death. Death in 8 cases, which is quite a high number. And hemiparesis and hemiplegia in so many patients. And more important is that these patients were not having, they have young fellows and young and healthy people with marginal symptoms. On the other hand, these are the negative issues. On the other hand, at the follow-up of 3 months, 133 patients are having no deficits and they are cured. Means you cure or you kill. So this is the story of lateral ventricle, these kind of tumors, central neurocytoma in particular. And these are benign tumors. If you see this was for 22 years, this patient, when he was not ready to get operated, when he was told you can have hemiparesis and all those things. After 22 years, he came and then I operated this patient for some symptom. He came and this was one tumor. And these meningiomas, of course, I don't want to talk too much, but meningiomas in this situation are in the atrium. They are as we know, they are benign tumors. You remove these tumors, the vascularity comes from choroid plexus in the midline. So the approach is through, if it is coming that far, you can come through the parietal. But in general, and epidermoid tumors are, of course, rare, and this is the postoperative. Intraventricular tumors, I published several years ago in this book with my experience of 50 cases in 2006. 2006. Now my experience is quite big, and this experience was, in my view, largest in the world. So these kind of intraventricular tumors, either you can come transcortical, or another beautiful operation is posterior interhemispheric approach, which is relatively easier and safer. And then you can work through in this tumor get, and you can have the choroid plexus and bleeding territory from choroid plexus medially, which is there, is relatively earlier in the operation. So these are the tumors. You can come interhemispheric, you can come transcortical. Transcortical is, we are relatively familiar with that, but interhemispheric coming through the posterior part of the corpus callosum, entering into this is a relatively safer. On the left side in particular, if the tumor is on the left side, I usually like to avoid the parietal lobe, because you can have parietal lobe signs because the tumor is large, retraction may be prolonged, and sometimes these kind of huge tumors, you can have issues. Another, you see, this is another tumor. This is another tumor, transcortical. I like to go interhemispheric now for most of these cases rather than transcortical, particularly on the left side. So these are the tumors, and we have got, now other thing is, for this kind of tumors, you can come, I had described, I don't use it now, but I had described for the first time in the literature, transfalcine approach to contralateral hemispheric tumor. This was the approach I described in 1995. Can you believe in 1995 I described this approach, I think, which was 30 years ago, thinking of coming on the contralateral side by a transfalcine approach was quite a radical thinking on my part at that time. Now, many people are using transfalcine approach for even intraventricular tumors, but I have completely not used. I use very rarely this approach, but this was the thing I described in 1995. Intraventricular tumors are a little bit strange, and sometimes there can be a recurrence of a very strange kind which we normally we don't recognize. You see, this is the tumor which has been removed, and this tumor has recurred along the surgical trajectory. You see this tumor along the trajectory of the tumor resection. It has recurred after a few years of surgery. So I had reported this kind of recurrence. You see, this is the tumor. I removed this tumor, and this tumor has recurred along the surgical site of entry and resection. Colloid cyst is another beautiful subject which I don't want to discuss too much, but colloid cyst, my series, this article, as I mentioned, is the most highly cited article on colloid cyst, and I had published in the year 2002 my experience. Now my experience is huge in this, and I love this operation. Colloid cyst should be removed always, interhemispheric, transcallose. Get a beautiful exposure. Identify the cyst, puncture the cyst, hold the cyst, and then dissect the cyst with 2 hands. You cannot have any compromise in colloid cyst. These are the benignest of all tumors. You remove, you cure. You try to play tricks with this tumor and put this and that and all kinds of unnecessary approaches you do. Don't. My recommendation is ventricle is large, come interhemispheric, open the cyst, identify, puncture the cyst, hold the cyst wall, dissect with 2 hands, and remove the cyst. And you will never have recurrence. Recurrence in colloid cyst is an extremely rare kind of situation. This was neurocysticercosis. It kept on migrating from the 3rd ventricle, from the lateral ventricle to the 4th ventricle. This was choroid plexus papilloma, which kept on migrating from one side of the ventricle to another side of ventricle after shock. So ventricle is important part of our life. We have to learn how to respect and how to understand the anatomy circumferentially. Majority of tumors are benign. We can give new life to these patients. Thank you very much. Thank you, Albert.
Dear Atul, thank you very much. Amazing lecture, amazing. Great information. Not only for young residents, also for me, I really enjoy. Thank you very much. It's a lot of tricks and tips. Yeah, but I may be very restricted in time, and I really want you come to my place and show for us your experience. I invite you, please, Atul. Come, welcome to my place, to my center.
Thank you, Dr. Atul.
Yeah.
Alberto.
And one, thank you.
How are you?
Fine, fine, fine. And Atul, one question for you. Atul, one question.
Yes,
How you relax the brain before approach? How you relax the brain?
The majority of these tumors, like lateral ventricular meningiomas, also have the huge ventricle. The temporal horn will be large, or some occipital horn will be large. Basically, you have to learn to retract. We have to learn, our life of neurosurgery has to learn to retract. We have to have very medial exposure. We cannot, we have to go right in the midline to retract the brain. Sometimes, rarely, Albert, I use ventricular tapping in cases I'm not able. But I don't like transcortical approach. I don't like to do transcortical. I like to go interhemispheric. I go through the corpus callosum. I go through the tapetum into the ventricle and hurriedly, quickly enter into the ventricle. As soon as I enter the ventricle, as soon as I start removing the tumor, majority of these tumors are soft, as we know. Majority of tumors are necrotic. As soon as we start removing, the ventricle gets relaxed. So quick operation. If you ask me what is my trick is quick operation. Go and enter into the area and quickly start demolishing the tumor.
What is about your relation to the lumbar drainage? Lumbar drainage before surgery, just to open the interhemispheric fissure? No.
I don't like to use lumbar drainage in these.
I just only my.
Yes.
Okay. Of course. Maybe my Professor Sami, some comments. Sami with us? Sami? Okay. Mehmet, maybe your comment.
Consigliere Antonello,
Sabino.
posso prendere atto?
Yeah, no comment, no comment. Totally agree with Professor Goel
Yeah.
about the fact that you know it's really true minimal invasive because it totally spared the cortex. This is my humble point of view.
Okay. Thank you. Atul, thank you.
We
Thank
come
you very
to
much.
the third speaker, I guess.
Okay.
Thank you.